I'm going to hand over to Ellie to give you some intro slides. I think I just wanted to acknowledge at the outset we're joined here by the whole open disclosure team, and Morgan Lucey's kindly presenting for us on the Employee Assistance Programme. But we are missing an important member, Angela Tyson, who has unfortunately had some unexpected leave, and she very much organised this webinar and spearheaded the agenda for it. So just wanted to, I suppose, acknowledge that at the outset. But I suppose the whole team are well versed and well briefed, and I will hand over to Ellie to do the introductory slides.
Thanks, Lorraine. Thanks, Lorraine. Good morning, everybody, and welcome to the Open Disclosure webinar. I'm Ellie Southgate. I'm the National Open Disclosure Manager, and I'm delighted to welcome you to the webinar, which will focus today on HSE's Employee Assist Programme and specifically how it supports colleagues following patient safety incidents. We're delighted to welcome back Morgan Lucey, Head of National Employee Assistance Services from the HSE's Workplace Health and Wellbeing Unit. We'll also be hearing from our own Lorraine Swanberg, Assistant National Director for Open Disclosure and Incident Management, and Mary Friel, our Open Disclosure Trainer and Educator. And they'll be following Morgan's talk, speaking about staff support following a patient safety incident and talking about peer-to-peer and line management approach using the AssistMe tool, which the Medical Protection Society have kindly given the National Open Disclosure Programme permission to use. So just as it says there, we'll be starting in a few minutes, engaging on some potentially triggering and emotive subject matter. So please, if you have questions, do engage through the chat box to ask those questions, and you'll be automatically muted, so you can remain muted throughout the webinar. The session is recorded, and we ask that you leave your video off, and as I say, your muted mic will remain in that status throughout the session for attendees. If you could jump to the next slide, that would be great.
Really, just give me a second.
Thank you. That's okay. It's already a bit of a sticky button this morning, slow to work. That's okay. As I say, the chat box is there for your questions, but also if you are having any issues technically, we do advise you to use the chat box to ask our facilitators for information about dialing in. Sometimes we found colleagues will have a better sound quality when they dial in on the phone, and we can, if you need that facility, please do ask for that in the chat box, and colleagues will be happy to provide the telephone number there. As ever, our webinar is accredited with CPD points when you engage live with it. So those watching back on YouTube later will not be able to access those, but those watching live, please do apply for certification, those certification points through our open disclosure shared inbox, and details of that are on the slide and will be part of the chat box that my colleagues will facilitate that throughout. So please do post your inquiries to that. Mary, do you want to stop sharing, and then maybe we'll try sharing again in a moment to get to those slides? But we, as I say, please do engage with the chat box to have that information about CPD points. As you can see, we have an ISL interpreter, and we're absolutely delighted and grateful to them that they can join us. And we do need two for this session. Being of a length, and we're grateful for their work. And so this is Dawn Kelly, who's interpreting at the minute. So thank you, Dawn, and she'll be joined by her colleague Sarah Faulkner will succeed her as they hand over. Equally, closed captions are available to aid accessibility of this session. So as Mary very kindly scoots through the slides to catch up to where I am, bless her, that's perfect. we have this slide of welcome for, as I say, our speaker, Morgan Lucey. Morgan Lucey has over 20 years of experience in frontline and staff support roles in health service organisations. He's a psychotherapist and a national lead for the Employee Assist programme, which provides individual and group support services to all sections of the Irish Health Service Executive. He's a strong advocate for employee wellbeing services and positive mental health in the workplace, and a special interest in expertise in the provision of mental health services and public sector EAP programs. So I'm delighted to welcome him and hand over to him at this time. Thank you, Morgan.
Thank you, and good morning, everybody. I'm delighted to get the invitation to speak with you and meet with you today. In a moment, I'm going to be sharing up some slides, which I'll be talking you through, and I will be, I know there will be another speaker for a number of minutes after I wrap up, but I will be staying on for the discussion and Q&A at the very end of the webinar. So just to let people know that. So I'll just pop my own slides up here. If you give me a moment, and we will start. So what I'm going to talk on today is the employee assistance program support for staff, and with a focus on supporting staff after patient safety incidents. I'll be talking about what the service looks like, what we provide, how you can access it, who's eligible. I'll be also talking about some of the line manager responsibilities, so people in leadership and line manager roles, and what the staff support responsibilities are there, because sometimes that's not clearly understood by everybody. So we'll try and cover that in a helpful way for everybody. So just to begin with, I'm not going to assume knowledge. So very briefly, I'm going to cover some kind of basic pieces about where we are situated in the organization, just to give you a little bit of context. We sit under National Corporate HR, and we are part, all EAP services are part of the Workplace Health and Wellbeing unit, and our sister services there are occupational health, the National Health and Safety Function, rehabilitation services, and organizational health as well. So what we do, again, I'm going to cover some of the basics. I know some of you know this already, but we'll just recap on it briefly. The employee assistance program is in every organization, including our HSE, is a work-based support service for staff and the organization. And what that means in plain English is that it is set up and resourced to serve both the staff and the organization. So our primary focus are the individual healthcare workers in the HSE that that need support, whether that's via counselling or critical incident support, and I'll cover all of the services we offer shortly. But they're our primary focus, and we work with them day in, day out. But we also serve the organisation. And in terms of staff counselling, I'll explain how that equation or how that model works, because it does differ. It's quite different in certain respects to normal traditional talk therapy. And we support people with the full range or spectrum of what I would call psychosocial issues. So any kind of psychological or social issues that are influencing their mental health. Very importantly, the service is free. People often ask us that. We assume people know, but we still get questions on it. The EAP service and EAP counselling is free to all HSE employees. And the access point, the main contact point, is our national EAP phone line, which is a 24/7 number, and that's 0818 327 327 or 0818 EAP on a telephonetic handset. So I said I'd talk in a little more detail about the supports that we provide. So our biggest block of work is counselling, and people often call us the staff counselling service, but we actually provide a suite of supports for a suite of different services. EAP counselling, what that looks like is we run a 6-session per issue model. So I'll just explain that in a little more detail because it is different from some other organizations, including from some other public sector organizations. So in recognition of the fact that the health sector is a high stress work environment, it's highly regulated, all the international research will show that and support that view. We have a 6 session per issue model. What that means is we have a model where you can come, like EAP counselling, by the way, is a short-term counselling model in every organization. That's the way it's always set up. That's what it's intended to do in terms of workplace counselling. It's not long-term therapy. It's always a short-term model. But in the HSE, you can come and receive 6 sessions. So supposing Morgan is involved in a workplace assault this week, and I reach out to the service, I will get 6 sessions, and most people come on average for less than 6 sessions, and that's true internationally as well in EAP counselling services. But I can come for that support now. If in 5 months' time, I have a bereavement, for example, I can come and I can get another 6 sessions. So it's not 6 sessions per annum, like in most organizations. It's 6 sessions per issue, and if say 4 months after that, I'm involved in maybe a dispute with a colleague or a manager and I'm having, a significant stress reaction, I can reach out for support and get another 6 sessions. So that's the model that we have. We have a hybrid model. And what that means is that we have a smaller specialist internal team of EAP counsellor therapists spread out around the country. And we also have a large external staff counselling partner. That partner is currently Inspire Workplaces. That's governed by the OGP, the Office of Government Procurement Public Sector Framework for Employee Assistance Services. Very rigorous framework. There's very rigorous clinical governance in place around that. And it's something we take very seriously for the overall service, not just for the counselling, but for our other clinical services too. One of the big blocks of our work that people are often unaware of is we do what are called manager consultations. So people in lead or line manager positions can confidentially consult with our internal EAP counsellors and on a range of staff well-being issues. And they might have a situation, it might be like one of those kind of slightly wicked problems where there's a couple of people involved in a long-running issue or dispute at work that doesn't necessarily fall into the HR box, but that is causing difficulty, and they might be unsure how to address it, and they will contact us and we will help them kind of look at that and unpack it and advise them on what supports we can provide. And that's used very, very commonly. Provide psychosocial support, which is brief practical support for people who maybe don't want counselling but are having a stress reaction or going through a stressful period and may wish to speak to somebody on the phone, for example. We provide a limited number of workshops on staff well-being issues within our scope of expertise. They're the things that you'd probably guess or imagine, like stress management, resilience, things like that. And obviously then, and this is very relevant to what we're talking about and looking at today, the Employee Assistance Programme Service has the remit for all critical incident debriefing in HSE services. And we have a model that we use called the CISM model, or Critical Incident Stress Management. And that model that we have agreed with the State Claims Agency. It's also the model that is defined in our national policies. And that's the only model that we should be using for actual debriefing after a critical incident or a traumatic incident, some of which can be patient safety incidents where there's for example an adverse death or other types as well. People often ask us about confidentiality, and really it's a critical question. Our brand, if that's the right word to use, our brand in EAP is trust, confidentiality, and neutrality. Those 3 words really sum up our brand. And you cannot run an employee assistance program, which is always a confidential staff counselling service. You cannot run that unless you have those things in place. And that's how people regard you in the organization, because people will vote with their feet. They won't come It's something we take very, very seriously. We have an excellent clinical governance structure, and we have a set of national standards that are available online. And to give you a few examples, I suppose, of what that looks like in our day-to-day work and how seriously we take that, we have an information management system that has, it has triple layer security. So that's the same as internet banking. That's the way we designed it. We have a bespoke system, and the data from those systems is kept on external servers that have a very high security rating. So the reason I'm explaining that is because somebody's data, in terms of who is attending, that data can't even be accessed by accident within the HSE. It's not possible. It's completely sealed, and that's how seriously we take the confidentiality piece. 80% of our referrals are self-referrals, and in general, when it comes to psychological support, especially in the workplace, people often want that to be private and very, very confidential, and that's their entitlement. And we honor that, and we take it seriously. So people don't have to disclose to their manager or any of their colleagues that they're coming, and there is no feedback on that in the organization, either to HR or management. We do provide some statistical reports, but all of that is de-identified and anonymized completely. And I'm happy to take further questions on that later if people wish. So I said that I would talk briefly around, I suppose, line manager responsibilities, and I'd really like to kind of put a focus or place a focus on how we manage stress. And I'm going to talk about that, quite broadly and I'm talking about, say, any of the issues that would bring people to want to access workplace counselling or EAP counselling. I'm going to broadly call that their stress reaction, and that will look very, very different for different people across different incidents and different services. But in terms of how we manage our healthcare worker colleagues' stress or distress, when they are going through difficulty in the workplace or outside of work. And actually, that's an important point because of the presentations that come into us. Work-related stress is always the number one issue. But when people come and we actually start working with them, we will often find with the majority of presentations, so with the majority of people who attend, it's a combination of workplace and non-workplace issues. So home and work, it's usually a combination in terms of what tips people over, in terms of reaching out for support. But in terms of line manager responsibilities, it's become evident to us, I suppose, over a number of years that this is a piece that's quite poorly understood by some people, or at least in some quarters. So line managers have specific responsibilities in terms of how employees are responded to, and I suppose how their stress or distress is managed by the organization. They are the people who have responsibilities for that. They have a legal responsibility in that role. So if an employee goes through, and it could be a patient safety incident or any type of adverse incident, and they communicate to you as a line manager or as a person in a lead position that they're experiencing stress because of this, there are a couple of legal obligations that we have. So where that has been expressed, a manager should always be referring to and following up using our HSE policy for the prevention and management of work-related stress, which was updated just a number of months ago, the end of 2023. That must be followed. It's an obligation. There's a workplace stress risk assessment that has to be completed if an employee discloses to us that they're experiencing work-related stress. And the reason we do that is because it's a really simple, easy to use, easy to understand and accessible template for a line manager to sit down with their team member or team members to run through and unpack what those stressors look like. So we identify them clearly, and then you look at how they can be addressed. So what controls or mitigation steps are you going to put in place? And it gives you guidance on the follow-up process around that, and gives you kind of a reference point for everybody involved to track back to. It's a really effective tool, really easy to use. And sometimes, you know, people have reported to me, managers have reported that they're not, if they haven't used it before, they're not confident, you know, in using it. And I always say, look, it, as part of that policy, at the back in the appendix, which people often don't read, there's a really, you know, plain English template that has been filled out already for managers. And it explains, you know, how the template is used, what it should look like, and it gives you an example of one that's already been filled out. And you can adapt that to your situation and your service. So the reason I'm also identifying that tool and that policy as a central policy after kind of, you know, incidents where staff may be experiencing distress or stress is that the risk assessment should always be completed prior to referrals into other services, for example, occupational health. And if or EAP, if you're doing a formal manager referral. So earlier on, I said 80% of our referrals are self-referrals. They are just over 80%. And then there's a certain number that are formal referrals. Those referrals always have to have written informed consent from the worker, the employee. And those formal referrals come from occupational health and from managers directly to consent, as I said. And ideally, you should already have, you know, done the stress risk assessment piece or be doing it in conjunction with the referral. I think, useful points that people are often unclear about and ask our offices all around the country about. So just going to move on briefly in terms of our some of the, you know, most relevant policies. There are many related policies, I suppose, in terms of staff support. These are the ones, I suppose, that people often cite and we find are most relevant in terms of these types of issues. There's the managing attendance policy, obviously, the rehabilitation of employees back to work, the one I already mentioned around work-related stress, and obviously our dignity at work policy. And the reason I'm signposting those is because I suppose anybody in a leadership or management position or in a supervisory position, you know, it's really useful to refresh yourself on these policies. Some of them have been updated quite recently, and there are some kind of key principles in terms of how we respond and our duties around that you should be au fait with. In relation, I'm just going to mention this, I was talking to some occupational health colleagues, they're a sister service of ours. I thought it would be useful just to name this as part of the presentation. If you are doing a management referral, employees can be referred by the manager to Oc Health, where the absence, any absence that goes over 4 weeks. Sometimes, again, there's a lack of clarity around that. That's the point usually at which people would make the referral or would be advised to make the referral. Or in some other cases, if support is required before that, with consent, that can be sent in. Alternatively, the employee can always self-refer to occupational health. As I said, we have a very similar system in the employee assistance program. There can be formal management referrals, but the majority of people self-refer. In terms of rehabilitation back to work, this can be a factor after some of those incidents in terms of the impact that it has on staff. And where there has been a long period of absence, Oc Health will advise the employee and the manager about fitness for work and any rehab requirements. And I would encourage people to look at that web content, and there is an excellent new HSE land module on that support service as well. There's just a couple of information resources here that we would recommend to people in terms of working with staff after incidents like this. I won't read down through them all, but they will be available afterwards. And finally, I'm going to say goodbye in a moment, but there is one thing that I want to share just before I take my slides down, and it's in relation to our critical incident stress management debriefing service. That's a service that is often invoked after patient safety incidents, and what it looks like is it can be either group or individual. Most typically, people will, you know, there's a number of staff that have been involved, and those staff can go to their line manager and request debriefing support from the employee assistance program. So our staff would go in, they were all certified and experienced in that model and receive clinical supervision. So we have a clinical governance structure around it, and they would go in and do work using an evidence-based model with staff after incidents like that, where there has been, you know, a level of distress that has been difficult. And as part of the work, we would triage who may need further support, and we can prompt people to make contact with us if they wish, or they can, you know, make contact with us then and there, or after the fact. We give people contact information, and they can link in after, you know, critical incident group support as well. And that is, you know, it's a support and a service that's used across all the different regions and across all the different services. One of the things in relation to eligibility, I have mentioned it, but just for clarity's sake, in terms of access to HSE EAP services, it's for direct employees of the HSE. So, and that's a legal point actually. Anything that is provided in this space happens under the umbrella of the legal employer-employee relationship. And that's why, in terms of eligibility, it's only HSE staff that can access our services. So for other voluntary hospitals, Section 38, Section 39 organisations, they all have their own individual staff support structures with EAP programs attached to them. So I just thought it'd be useful to mention that for clarity. And I'm going to stop there and thank you for your attention. I'm going to hand you back over to our moderator. Thanks, folks.
Thank you, Morgan. That was really insightful. It's in particular that critical incident piece, because a lot of our staff deal with very serious incidents that might be rare. So it's just really important that people know that that support and service is available for staff. I'm going to talk to you a little bit about just our general knowledge about the impact of patient safety incidents on our staff. And Mary Friel's going to talk to you a bit more about the Assist Me tool that we advocate in our training. We get a lot of positive feedback on, but there are some of our really key, I suppose, support mechanisms in terms of how management.
Showing the webinar piece.
Oh yeah, thanks, Mary. You're sharing. It just needs to go into the PowerPoint. You know how you did that earlier. I'll start speaking to it in any case while you get up the slides. So we know patient safety incidents can have a detrimental impact, of course, on the patient, the service user, and their family and friends. But it does have a significant impact on our staff. It can have a significant impact on our staff. We had a very nice webinar by Professor Eva Doherty the last time, and she very much talked in a lot of detail around the impact of the second victim. I'm just going to reflect on some of those, I suppose, data and research, so that we recognise it is a real problem and it is a real challenge internationally. In the HSE, staff are our biggest and most valued asset. So it's important that we support them, that we protect them when incidents like this happen, so that they feel psychologically safe in that, and that we influence culture around that. We have over 150,000 staff in the HSE that all go to work. But I would say the majority of times go above and beyond their roles, their duties. And as we always say, nobody comes to work to be involved in an incident for harm to occur. But we do know that healthcare is complex and that incidents do happen. So this webinar is very much, I suppose, focusing on that staff support piece. Next slide, please. So these are some of our references. We use this in the HSE patient safety strategy. So we know from a number of different pieces of research, the kind of prevalence in terms of incidents. We quite fortunate that we did have there was an Irish study in 2009, which was repeated again in 2015, which showed similar results. So in acute hospitals, 1 in 8 acute hospital admissions, the patient is involved in a patient safety incident. There's some stats around kind of preventable harm, preventable deaths, and then also some of the financial burden associated with incidents and the impact that has on healthcare. which we know is obviously money that we could use and spend to provide healthcare by other means. I always like this slide, and I suppose I labour this point quite a bit whenever we talk about the staff support piece. This was the research by Scott and a few other colleagues, and they really outlined the kind of well-recognised steps or events, or I suppose the aftermath of an incident. So how does it play out for patients?
Just make sure it's okay, because I'll have to go on.
Oh, Mary, you might just have to mute yourself. Apologies.
Apologies.
Thank you.
Thank you.
You're right. Don't worry. I know you're working away. Thank you. So when an incident initially occurs, particularly if it's a serious incident, they can that individual staff member is reported to experience chaos. So that incident is recognised. There's almost that shock factor as to how could this incident have happened. And then there are some intrusive reflections where the staff member might play the incident over and over again and reflect on what happened and try and understand what happened. Then in some instances, in most incidents, there's there can be the kind of experience where the individual staff member wants to restore their own personal integrity, managing gossip, fear. I think in Ireland, while we have a lot of advantages in terms of our networks or kind of close proximities or communities that we have within healthcare systems, they can be small. And certainly when incidents happen, it can be the case that a particular service, particular team become aware of that. So the challenges of managing that in your own personal experiences around that. It's called in the research enduring the inquisition. So that's obviously where the kind of incident review person process is initiated, realizing how serious an incident might be, and really kind of maybe being a little bit lost and trying to identify where staff member can go for supports. Important, obviously, a key step for us is that they do ascertain that first aid, that emotional support, and that they can access that. And sadly, the research has demonstrated as well that there are often three key outputs when a staff member is involved in an incident. So often they might struggle with it, they might continue to work, try and cope with that particular incident. And that's really important that we pick up on that, because as you know, if a staff member is distracted or anything like that, it makes ongoing work quite challenging. Now, some staff, they can thrive from the incident, they can learn from the incident, in particular leadership roles, they might be able to talk about the incident and turn it around and really be a driver for improvement as to what the kind of contributory factors were around that incident. And sadly, we also know from research that in a number of instances, the staff member actually leaves the healthcare profession. Next slide. So recognizing the staff response to a patient safety incident, if you're a manager or a peer and your staff were involved in an incident, there might be some signals that you would be observing in terms of their struggles following on from the incident. So there might be a feeling of incompetence and isolation. I think we're so diligent and conscientious in healthcare that can sometimes be our worst enemies and be very reflective and critical of ourselves. There can be denial of responsibility. There can be emotional distancing, feeling of overwhelming guilt, symptoms of post-traumatic stress, and an experience that is highly intense, that the capacity to imbalance an individual at an emotional, cognitive, and or physical level. Okay, so that struggle with trying to cope with ongoing work. Next slide, please. So as I mentioned, it can be a very stressful experience, especially if the incident is more serious. I think Morgan's kind of advice in terms of the critical incident resource that's there is really important, and important that we do increasingly access that. Critical incident has historically been used to describe traumatic stress, combat fatigue, and rapid onset burnout, something that we're reporting and finding in healthcare also. We know that there's a higher rate of mental ill health than other professionals in healthcare, And sadly, there is research and evidence as well that there's an increased rate around suicide and that. So we really need to do everything that we can to look after our staff. Next slide, please. This nurse, a midwife, her name is Jacinta Saldana. You might not remember the name, but I'm sure you will remember the incident or the scenario, which was very much played out in the media. This was the midwife who took the call when Australian DJs phoned one of the London maternity hospitals, trying to ascertain if Kate Middleton had given birth in that site and wanted to speak to the clinicians and that. And this midwife took the call and handed her over, explaining that those almost hoax call that those DJs were actually relatives of the royal family and wanted to get an update on Kate. After that incident, there was a lot of media attention around it. This midwife really struggled, and some of the statements that you saw from some of the email correspondence to colleagues I've quoted here, her husband at the inquest really reported that she felt a sense of shame following the incident, and as indicated there, sadly, she committed suicide. So these were some of her words in her email to her colleague. It's all my fault. I feel very bad about this to get you involved. If there was anything I could do to mend this, I would do it. I'm very upset and don't know what to do. Things are all going in the wrong direction. Please blame me for this. I accept the fault was mine. I should have checked before I gave the call to you. I can only say sorry. Please accept my apologies. So this, what started off as a hoax, but was actually an incident, had an absolutely detrimental effect on this staff member and her family and the organisation, I would expect. Next slide, please. Again, some research here from Sweden. They did some qualitative research in terms of a group of healthcare staff who all experienced adverse incidents. They showed signs of emotional distress, often long-lasting. And they explained the impact that had on them as professionals, and particularly honed in on the organisation's response to those incidents and where they felt there were some gaps. The most informants reported that they lacked organisational support, or that they received support that was unstructured and unsystematic. Further, the formal investigation seldom provided adequate and timely feedback to those involved. The insufficient support and lack of feedback made it more difficult to emotionally process the event and reach closure for those staff. Next slide. This is kind of how they grouped the feedback from the staff members. So it affected them emotionally, their performance, and they gave feedback in terms of the duration as to how long they experienced those symptoms. So emotionally, they could not believe what happened and that they had been involved in an incident. There was sadness, anxiety, and they regularly relived the events and had flashbacks. They felt guilt, shame, were worried about criticism, and they themselves were self-critical about the events. More than half described taking extra care in performing their work afterwards so as to avoid problems. And they said they doubted their professional judgment and sometimes even their career choice. And they explained that for some, those feelings lasted for a few months, but others explained that it actually was more continuous, lasting for over a year, and really having quite a lot of difficulties around this. Next slide, please. So what does staff support look like? So 25% reported they received the support they needed from the hospital management, which is only a quarter of that of those staff. The majority reported that it was insufficient. Again, there was no support from their closest manager or any hospital representative. Most informants turned to their colleagues and their family for peer support, and that's well documented and well reported in other pieces of research as well. They reported their challenges in terms of a lack of structure and routine for handling those events. And they reported that there was a lack of open discussion about the adverse events in the workplace. And they felt that the peer support was crucial in the aftermath of the incident. I'm going to hand you over to Mary Friel now to talk more about the Assist Me model. So just to highlight in the HSE, obviously Morgan gave you a very high level overview in terms of the employee assistance program that we do encourage you to tap into when incidents or serious incidents occur. But this is probably a bit more to the floor for the manager. This is something any line manager can use with their staff as well. And I'm delighted to report that we're in Cork today to do some after action review training. So just the benefits around debriefing and so forth after an incident. But over to you, Mary. On mute now. Sorry, no, I prompted you there really. Thank you.
Yeah, thank you very much, Lorraine. Apologies for the background interruption. Yeah, so thank you, everyone. And I suppose, as Morgan said at the outset, some of this is a recap for people. We're very mindful of that. We have a lot of open disclosure people on the line, so we're very appreciative of you here for this part of the presentation. So following on from Morgan and Lorraine, I'm just going to cover a little bit of the Assist Me model that we use in open disclosure. So really this, you can see the staff support here as a core principle of the open disclosure process. And we now know that recently it's been further reinforced with the National Open Disclosure Framework launched in 2023 by the National Patient Safety Office of the Department of Health. And I suppose it specifically requires that services must ensure that staff affected by patient safety incidents are being supported in the immediate aftermath of an incident and on an ongoing basis for as long as is required, recognise the impact, I suppose, of patient safety incidents on health and social care staff. And I think Morgan has covered that very well by giving us an outline of the opportunity to have those supports and how that might work, what it will look like in reality. Just to give you some background on the Assist Me model, it started out originally back in 2013, it was updated in 2021, and I know that Morgan has always been very supportive and his team in EAP by making sure that it's up to date and it's relevant and current, aligned to the national current, I suppose, work in relation to EAP. So that's an ongoing piece, and we are looking at reviewing, and there's only some minor updates to do, so that will be happening over this year. So we're appreciative of that. It is based on the Assist, on the MPS Assist model of communication. I suppose ultimately it was developed to provide some practical support and guidance for health and social care managers and staff. You can see there in relation to understanding the potential impact of what happens to staff when they're involved in a patient safety incident, recognising and managing some of the signs and symptoms. And often that might well be referring them on, as Morgan and Lorraine have suggested. Supporting staff themselves, what can we practically do to support people, and what information and signposting is available. So that resource is there, I suppose, primarily for that. So the resource really provides information about recognising the staff responses. Lorraine has outlined some of it there, but it really does drill down a little bit of that, and it is quite practical. I suppose when something happens in health and social care services, we know it's better to have this information available and the numbers that you may need. So in some ways this helps to do that. So it talks about how people cope when they're impacted by patient safety incidents, and it does refer to the CISM response that Morgan has also mentioned. It also talks about when you might seek medical advice and further resources for staff. Just to go into it in a little bit more detail, some of you will be familiar with the Assist model of communication that we use as part of our communication process for open disclosure during the patient safety incident and incident management process. So when we look at the Assist Me, we really do advocate the same approach in communicating with staff that have been involved in a patient safety incident. So very much acknowledge with empathy what has happened and the impact on that person. Because as we've said, nobody comes to work in health and social care in a given day to be involved in something that's going to harm or hurt a patient and then ultimately have an impact on themselves. So we're going to also assess the impact. We're going to inquire how they are, how they're coping, and where they're at, I suppose, in response to what's happened. We're also going to say we're sorry that this has happened to them today, that they've found themselves in this position, I suppose, regardless of the circumstances, and that's the key thing. At the moment, we're talking about the supportive process and really to acknowledge how challenging this is for the member staff involved. We are going to use the S then for story. We're going to allow them some time and space to talk about what's happened. And I'm mindful I'm saying this, and we know that in reality there's very great challenges in the work environment where often the staff member, maybe a medic or a senior staff member involved, who actually has to be involved in making sure the patient or the service user is okay. That's always the top priority. But alongside that, this person may be also, so they may have to look after the patient, remedy the situation as far as possible, but also they may, we have to give them time as well to look at how they are and what's happened. So sometimes there's a parallel process going on in that very initial period. I mean, obviously, ideally, we look to see, can we move the person aside? And I'm not going to go into all of that in great detail at the moment, but it is very important that we give people the opportunity to talk about what's happened to them and how they are. That idea of taking time out away from what has happened, and that's very challenging, we know, but it is very important that we, as particularly as managers and peers and colleagues in the system, that we include that in our response to a staff member that's been involved in a patient safety incident. We then also would say that we must demonstrate that we've heard what they're saying, and it might take the form of that, I'm hearing what you're saying. It's that idea of the chunk and check and the double piece of communication, the two-way piece of communication. And we do ask them, whether or not, and this very much depends on the situation. I'm making very general comments as a guide, and obviously it would be led by the individual person and the circumstances. Often people do find it reassuring to hear that a more senior manager or a peer has been involved in something in the past, and I think we're getting much better in healthcare at being open to acknowledging that. Most of us that have been around for any length of time in services can talk to an incident we've been involved in, or a colleague that we know that it has been affected. So sometimes that can be helpful as well, but obviously it depends on the individual and the circumstances. We also would encourage that we inquire how they are, and I suppose this is very much like, a lot of the time this tends to be staff are not necessarily as aware about the incident management process, what happens next, will there be an investigation, what does that look like, and obviously that there's a time appropriate part of that as well, but often people do want to know what happens next and what do I have to do. So and also, do they have any particular questions? So important to give that time. The solutions then, we talk about this when we talk about it's also very important for staff. So, it's very important that people are offered the opportunity to come back to talk to you. We often talk in the training for open disclosure, we use a scenario-based approach, and we look at how would you support a staff member in a given situation. And I suppose this is something we pay particular attention to in terms of how do we make sure that the person is supported. We arrange that we're going to stay connected to them. Do they stay at work? Do they stay on the shift? Do they go home? What's at home to support them? What does home look like? Insofar as possible within our manager or colleague role to support people. So this is listed out here. It's really, I suppose, ultimately looking after the person and giving them as much support as is necessary and what is practically possible. And that idea that you can come back to me, this is my number, and then I suppose a realistic piece within that. So ideally we would recommend that people are clear about that at the outset, that it's a core part of your work. People are not going scrambling looking, I suppose, for solutions and numbers then when something does happen, because as we know, unfortunately, there's a lot of other competing pieces for staff's attention and managers' attention. So formal emotional support also and I don't need to go into this in too much detail because I think Morgan has covered it very well already, but it really is assess the immediate needs and discuss with the member staff. So we very much have them involved, and that we make sure we check their consent, if we're going to contact someone else on their behalf, very much keeping the person at the centre. We provide information about EAP, and I know that in talking to Morgan in the past, and Morgan might talk to us afterwards when we have time for some questions, a lot of the time staff don't want an exclusive focus on counselling or emotions, so it's to avoid the tendency to say, like, you're not coping, so therefore you must go here, and really, I suppose, more stronger a focus on psychological support and what that might look like, because it's a wider sphere or a wider spectrum. Morgan has talked about the CISM piece there as well, so I think that's a very useful resource, and there's further information available there, and we will make these slides available to you afterwards. Also, occupational health, and I suppose Morgan has talked about how that links in with AAP and where that sits. And the phone number, I suppose, I often am out and about in services and colleges, and we do see the EAP support, as Morgan said, it is a brand. There's a number, and increasingly we see it available, and ideally that should be available on units and in services, so people know how to access it themselves as well directly. I'm just keeping an eye on the time here now. So supports as well, practical support, provide an opportunity for the member of staff to take time out of their normal work if required. And I suppose I've touched on that already. It often depends on what's most suitable for the person. And then as a manager, you'd have to look and assess that depending on the circumstances. Sometimes it's not helpful for people to be put away from their work situation. And in other situations, people may just need to not be in the working environment. So practical support, we've talked about that, encourage the person to write up their recollection of the incident as soon as possible for their own record, and ensure that they're kept up to date and involved in the incident review and open disclosure process. That's often a very important piece that we hear for people. They worry about the patient, they worry about the outcome, and they do want to know what's happening. How are they, and that's an important part of that. Provide information and support in relation to communication, who's going to contact them, when they're going to be contacted, is it Tuesday every week, every 2 weeks, and really negotiate around that, but it's clear when people, I suppose, leave, how that's going to work. Ensure they're encouraged to provide their insight into the steps. And if there's anything in particular, then we're always focusing on reducing and mitigating risk. And certainly from an incident management open disclosure perspective, if there is something here that's crucially important that can reduce the risk of this happening again, we take that into account. And we know that staff involved in incidents always, in the main, want to be involved in those solutions insofar as possible. So establish the learning from the incident. We've said that as well at an individual and organisational level, and provide ongoing support. So that's a crucial part of that. The travel then is really, as I've said, I've touched on that. It's about continued support and reassurance going forward and throughout the incident review and the open disclosure process. So depending on what happens next in terms of the incident review, their part in that, their opportunity to be involved in that. But this piece at the moment is very much emphasising the need to be supportive of the person, as opposed to going into full inquisition mode. I suppose we would say that that's a parallel process that runs alongside this. Maintain contact, monitor progress, and moving forward, very much on the basis of what Lorraine has said, to prevent the risk of someone I suppose going home on their own, ruminating, to use that term, but and things maybe going down a much more difficult track, that we're very clear how we're going to support them, who's checking in with them, and what the process is for that. And ultimately really providing guidance and support for their return to normal work. A lot of the time people are worried about that and concerned about that, and that might not be the immediate priority, but that we factor that in and we're clear about that. And then the end part, really, I've touched on this. This is about reaching closure of the event, that we're not continually bringing the event up if somebody has come back to work after a period of time off, that we've had a discussion where we look at the boundary and closure on that. Establishing of the staff member has reached the stage of closure of the incident. And we do know that unfortunately some of the incident investigation processes, the coroner's case, et cetera, can go on for quite a long time. So I suppose it's important that we support that, but that we also have the door open if people require further assistance or support. And Morgan has touched on that as well when he referred to the opportunity for people to come back if they've had a 6-week period, that they can come back to EAP for future episodes. And I think from what you're saying, Morgan, that there's opportunities to review that and look at that. So I think that is important as well, and that we review the support provided. It may change, as Morgan said at the outset, often people's home situations, I suppose, and other factors then also contribute to their ability to be supported and their resilience around returning to work. So consider feedback and establish any learning that may benefit other staff is also crucially important. And this piece here, then, we're talking about really what's important following a patient safety incident. This is detailed in the Assist Me. I'm not going to go into it in too much detail. And I suppose when I read it myself, some of it can maybe seem blasé, you know, taking time to relax when somebody's very distressed at the beginning. But I think it's ultimately a very good guide, and it's got some key pointers and, you know, key tips to keep an eye out for, things that you want to avoid, I suppose, falling into it. It really talks about structure, what would support, and I suppose ultimately this is normalizing something that is not a normal event. I think that's so. It's to really make people see that, well, this is happening and this happens to other people, and that this is something that can happen. So I think it's quite helpful in that regard. Yeah, and also that reference to contacting your GP, EAP, and occupational health. So where can you get further supports if needed? There's a list of don'ts here as well. And again, that's very much down to the individual, but I think it's no harm to have it there for people just to be prompted, I think, as you go through it, that really this isn't helpful and this may be contributing to the problem of the situation. So they're there. Seeking medical assistance, I've touched on that. And it does talk about people experiencing suicidal feelings and symptoms associated with depression or despair. So there's a reference to that as well. Obviously, that's quite important in it. And about people if they, you know, if you don't feel ready to return to work. And I suppose, yeah, it's really looking at how we support people in a bit more detail. So this is also included on the Assist Me resource. And just to say, this poster might be something you want to have in your work area. It's a good prompt as well. And we've also shared the links here. You can Google this resource as well, but the links are here to the Assist Me poster and the Assist Me booklet for people who would like it. And just very quickly, as we come to the end of the presentation and I hand over to my colleagues for questions and answers. I mean, ultimately, all of this really is looking at the impact on patients. And while we're talking about the impact on staff, and we know that we have to support staff to look after the patients and the service users and their care, ultimately, we see that when we look after our staff well, it does impact well on patients. It has a return, and that's important. I know that Morgan outlined the principles of the EAP service, I suppose, and trust was a core part, and always we want to retain that and build on that. That slide. So I've come to the next part, and my colleagues are joining me here now. So thank you.
Thanks, Mary. Thanks, Mary and Lorraine, for your input there. There has been good engagement on the chat, and I'll just launch straight into it for purposes of being keeping to time. A lot of questions are prompted perhaps by your statements around support for services that are not direct, where HSE is not the direct employer. So thinking about those Section 38s, and indeed separately questions about agency staff. So if we just take the first one, we had questions about the risk assessment, that workplace stress risk assessment. Obviously, colleagues were saying it seems a good model, a good approach. But if they're in a Section 38, questions about whether it was appropriate to use that, was it right to use that, and where people should go if not to EAP. Presumably HR would support there, but I'll hand over to you there, Morgan.
Okay, thanks. There are a couple of questions there, and I'll try and cover them. Let me know if I'm missing anything. One, it's a really good question, and I was monitoring the chat there after I came off. Section 38 and 39 staff and voluntary hospital staff, they have their own staff support structures. And to the best of my knowledge, they all have EAP counselling available as well, but they have a separate staff support structure to the HSE because they are their direct employer, and they have a legal obligation under employment legislation to do that, and under health and safety legislation. In relation to agency staff, it's a little bit of an anomaly. Strictly speaking, it should be the agency that caters for that. However, during COVID, it became evident to us that not all of the agencies had a structure in place. So from a duty of care perspective, I did make representations to senior stakeholders in the organisation and got agreement that we would provide access to agency staff who are, say, working in the same ward or on the same floor as us, that they would have access to EAP counselling via our external provider. And the reason for that is that the majority of staff want to see an internal EAP counsellor, and we have a relatively small internal team. Nationally, there's 16 counsellors, but most staff want to see an internal counsellor because often they feel like they understand the culture of the organisation, the differences between disciplines, perceived pecking orders, the local culture in a service or a hospital, all of those things, and they don't have to explain that to them. And for that reason, and there's very high demand. So for that reason, we do give agency staff access, but it's to the external staff counselling partner, and they get access to that by ringing the EAP national phone line. Could you prompt me on the other parts of the question again, please? Sorry.
No, not at all. You're right. So I bolted two together. There was, you kind of covered off where colleagues should go if there's Section 38 to discover as to whether the risk assessment is appropriate to use in their service.
Yeah. I think, look, the risk assessment is, as I said, a very accessible tool. I've used it myself. I don't just recommend it to people. Anything I'm talking about today of experience of using it myself as a manager. I'm not sure if a similar version is available or contained in HR policies of the various organizations. It is there in some of them, but I don't know if it's there for all. But risk assessing any reported stressor is actually a legislative responsibility. So whether it's there or not, there must be a way of risk assessing a hazard or, say, work-related stress, for example, and the psychosocial risk attached to that. We are obligated, not just the organisation broadly, but as line managers. So if it's not clear, I would contact your HR department and ask them for guidance on that. They may link with you or link you to their occupational health and safety professionals in the organisation. Yeah.
Thank you. That's brilliant. Just building off your comment there about being a manager and employing that risk assessment yourself, I wonder if you could speak a little bit to how to engage staff who, for whatever reason, might be reluctant to engage in this process. should they not want to engage in risk assessment? I know obviously you mentioned that there's manager referral, self-referral processes. Maybe touch on a piece of that, and then if I may couple another question into it. Another questioner was asking about what to expect when they first engage with EAP in terms of triage and so on.
Okay. I think in terms of using the workplace stress risk assessment, it is genuinely of benefit to people because, and I've had this conversation with colleagues, with staff members, when they might be unclear and might think that it's part of some, for example, a HR process that they're unsure about moving into, and it's not. It's actually a tool to help everybody, and what it does is it's really helpful to the employee because it's documenting the details of their work-related stress. So it's defining what it looks like, what's causing it, and it's helpful to the manager because you're unpacking that detail and understanding the nuance of it. And then as well as defining what it is and identifying, what's creating it, you also look at mitigation steps or controls that you're going to put in place to try and either, obviously the ultimate goal is to get rid of it or to eliminate the stressor. That's not always possible, so you might be looking at steps that you're going to put in place to minimize the impact of it. And it also acts as a tracker, because what you would typically do is, say, 2 weeks later or a week later, depending on the situation and the environment, you would be meeting again, and you both get a copy of this document, and you refer back to it and say, okay, this is what it looked like then. How is it now? How have we gotten on with executing the steps that we agreed we put in place? And there might be some that are, specifically the role of the line manager, and obviously they are actions that they need to take away and put in place. And there may be pieces that are, attaching to different people, maybe to the employee and the manager, or the staff member and the manager. So, and then you will meet again, perhaps 2 weeks after that. So it's actually a tracking device that's really helpful, because sometimes these things can kind of get kicked to touch, and in a very busy environment, they're not followed up. But this actually puts a time scale around it and a template. And I have found it very useful in the past because it's in plain English, it's in black and white. The two of you have the same record of it, and it enables you to follow it up and track it and monitor how it's going. So I would say it's very useful in that regard. In relation to the second part of the question, what people can expect when they contact the Employee Assistance Programme is that they will speak to somebody. So that will either be one of our counsellors. So as you would expect, they are in clinical sessions a lot of the time. So if you don't speak to one of them, you will usually speak to one of our administrators. If the counsellor is available, you will be able to speak with them, but sometimes, they may have to call you back. Or you might come through and say, look, I want to avail of EAP counselling. I work in such a hospital or in a community service, or you might be an administrator, you might work in the canteen. All grades and disciplines use the service, and they can also just set you up for an appointment, and you will come in and do your assessment with the counsellor and begin your sessions. I said we've a hybrid model, so we've a 24-hour phone line. If you have a preference, and some people do, if you have a preference to link into our external service, then you will be linked through to their call center, but they don't have, I suppose, the difference between other providers and us is that if you ring the staff counselling line, say in the evening or at night time, there is a counsellor available. So with some other providers, you will get through to a call centre, you'll be talking to a telephone operative, and there are no counsellors available. But with us, there is always a counsellor available, and sometimes you will get to speak to them directly. If not, you will get to speak to one of their colleagues, and you will get a call back from them. So that's, and in terms of how they're triaged, they would ask you for your basic details. That's, normal in terms of what you'd have to provide to any clinical service, and then you would explain more of the detail to the counsellor when you sit down. I mean, in greater detail. That's what you could expect, and you can expect to be treated with empathy and respect, because people know that when they're reaching out for support to our services, they're generally, in a situation of stress or distress, and we're aware of that.
Thank you. And final question, and I think one close to anybody that's been involved in a patient safety incident or indeed any kind of incident, asking about if it's been some time since it's happened, but potentially it's still symptomatic or it's still impacting lives, just to confirm and reassure and support staff to know that they can engage with the EAP even after some time.
Yeah, that's actually a really useful question and an important question. I will answer it, and I might wrap a couple of final points into it. So that is not an infrequent presentation or not an infrequent occurrence. We see that quite often where people are, and look, in general, say colleagues on the webinar this morning and more widely across the services, in general, people are used to working in very busy, high pressure environments. That's the norm in most of our services. They are very busy. There can be adverse incidents, you know, of across the full range or spectrum. And very often, you know, people will be like, look, I need to keep going. It's busy, or I think I'm okay. And then they might notice a couple of weeks later, or even a couple of months later, that they're getting intrusive thoughts. They might be getting triggered by a whole range of different types of triggers, and it's bringing back memories or, you know, feeling states. There might be, you know, or it might be impacting their sleep. They might notice that it's in their interactions with colleagues or at home that they're more impatient with people and they don't know why. And eventually they get a moment of clarity and go, aha, it's linked to what happened, you know, on such and such a date. So that does happen. I was working myself with somebody quite recently who had been involved with an adverse death over a year ago, and had realized that occasionally it was coming in, and, you know, she was ruminating on it, and she was getting kind of flashes back to it, and she came in. So all of the internal EAP staff counselors are trauma certified. They're all EMDR trained, and of our external counselors, there's over 400 of those on a roster nationally, and over a third of those are trauma certified. So we've a very large cohort of therapists who are able to do that work for people who've been involved in quite complicated or difficult incidents if they need to access that type of therapy. Not everybody does. And I'd like to emphasize that, actually, because often we bandy around words a little bit carelessly, saying that everything is trauma or traumatic. It's not. Sometimes people have a high stress reaction, and as Mary said a while ago, it's important that we normalize their reaction to what is a very abnormal event. But having that type of reaction to a really abnormal or, you know, critical incident is, you know, we do a bit of what we call psychoeducation with people, and inform them that that's actually quite normal given what you have been through, and that will be part of the process. One of the things I just wanted to pick up on one or two earlier points just to close, if that's okay. People were asking about EAP awareness. So on our web content, on our web page, which you can Google you can reach by Googling HSE EAP, there are high resolution printable posters for the EAP service that you can put up wherever you are. Also, somebody mentioned the 6 sessions, and just to emphasize, that's not necessarily on 6 consecutive weeks. Most people want to spread them out, and they might only come every 2 or 3 weeks. So you can spread that out, and in very complex cases, for example, where there is a trauma reaction, where we've assessed that, you know, people can avail of a clinical extension. That is always based on our own clinical assessments because we're a clinical service, but that is available to people where we deem it to be necessary. Was there anything else? I think that's it, if there aren't any other questions. Actually, one final note. Obviously, if there are, we've been talking about critical incidents here, and many of us who've worked in frontline services over the years have been involved in them at one point or another. So if anything we're covering here this morning is, you know, triggering people in any way, and again, I would say there's no shame in that. It's very, very common and normal. But I just want to say, if it is triggering people, you know, please do consider reaching out to the EAP counselling service, because that service is available to you. It's free and it's confidential, and you don't always have to manage that stuff all on your own. I always say that to people. Not always, you know, will I be able to manage? The question is, do you need to carry that all on your own? answer is no, you don't. So please reach out to us if there was anything triggered today. Thanks.
Thank you. Thanks so much. Just one final one, if I may, and it's more a broader question, perhaps not exactly for EAP service, but people are asking about support for families of employees and how that exists.
So the short answer to that is that we unfortunately don't provide or extend EAP support to families, and I believe it's a resourcing issue. We have a very large cohort of staff. Not all organizations do, and traditionally we haven't. So to date, it's not something that we have offered. It is only for our own employees. That's as it stands at the moment. Yeah.
Thank you. And thanks so much for taking the questions and giving us your professional insight and experience and knowledge. It's been really supportive and great. And colleagues are sharing their thanks, and there's lots of thanks in the chat box. So really appreciate your support there. Thank you, Morgan. I'm just now going to move into some comments to wrap up the session. If colleague wouldn't mind sharing the presentation again, so I can keep reading from my screen. That's ever so kind. Thank you so much, Mary. So we just wanted to wrap up by giving you some, that's perfect, thank you, just some updates. We are busy on our Patient Safety Act Roadshow, and with the project management of the implementation through the implementation working group and its associated work streams. You'll have met many members of the implementation group and the work streams because they've been supporting these webinars as well as the programs of work for implementation. Indeed, our next webinar in July will focus on the notifiable incidents of the Act and will draw on the insight that's been gathered through the extensive preparatory work of the implementation group. And I'll speak a little bit more to that in next slides. If you have any questions about Patient Safety Act or indeed anything you've heard today, please do get in touch via our inbox. But know that there are already an array of resources that may be able to answer your questions and offer further detail that you might be looking for, and these were listed on that slide, and you know they cover off the webinar, health matters articles, and our newsletters. And one thing that has been really supporting our preparations for implementation is hearing your questions on the specifics of implementation, particularly in your areas. So please know that all of your inquiries are helping to shape our guidance documents. So if you have any, and particularly in relation to the notifiable incidents, please do forward them to us and we will have them considered as part of that next webinar. Thank you. Next slide. And please don't forget that the resources are available on HSE land, and do support your colleagues to complete their mandatory e-learning module on open disclosure available on HSE land. That's the communicating effectively through open disclosure. Module 1 is the mandatory one, and then the second module, thank you, you're keeping up beautifully, wasn't it? And module 2 is for everyone involved in the delivery of the open disclosure meeting, and it's applying principles to practice and it really does deepen the understanding of the open disclosure process and supports communication of information and the apology during the open disclosure meeting. Thank you. Just wrapping up again, as I said, with some final notices. We do have our webinar on the 17th of July next month, same time, 11 on the Wednesday the 17th, and as I said, this will focus on notifiable incidents, and we'll have more information about that particular webinar forthcoming. Moving on, we are as ever sending an evaluation following this session today, and we'll be ever so grateful for your feedback on that. It is a brief survey, but enormously helpful to informing our work, and thank you in advance for your time and contribution to this. We are on the next slide, thank you. promoting on behalf of our colleagues that deliver QPS Talk Time the details of their next edition on the 25th of June, Tuesday 25th of June, which will work to promote Clinical Audit Week, which is taking place that week, the 24th to the 28th of June. And indeed, colleagues that are engaged with the Patient Safety Act will know that clinical audit is part of the provisions of that act. So I would encourage anybody that's interested in how the implementation of the Patient Safety Act will affect their services to engage with that talk time and that week. Equally, I'm just going to very briefly talk to the National Sepsis Summit, which is calling for abstract submissions. The deadline for submissions is the 5th of July. And the theme is Early Treatment Saves Lives. For more information about how to submit an abstract, please go to the Sepsis Summit website. Just finally, I'm going to hand to Lorraine, who's going to conclude with some comments.
I'd like to say pearls of wisdom, but thank you everyone for the webinar today. I just wanted to give a big thank you from the team, myself, the HSE, to our dear colleague Angela Tyson, who is retiring at the end of this month. As mentioned, she unfortunately could not attend the webinar at short notice, but obviously her passion has always been in terms of open disclosure, openness, transparency, supporting patients and their families, but also the staff support piece. She's been with the Open Disclosure Programme for over a decade, and I'm sure you'll all know her. She's a very prominent figure, has been leading the programme through adversity, through challenges, but always has done so with her compassionate, kind approach, and always with a smile. And we will miss her dearly over the foreseeable future, but we wish her the very best in terms of her retirement, and hope that she gets to enjoy lots of new hobbies and her grandchild and spending time with family. So we just wanted to acknowledge all the work she has done, and for setting up this webinar series, which always receives a lot of positive feedback. So big thank you to Angela, and thank you to the team today. Thank you to our lovely interpreters, Sarah and Dawn, and thank you, Morgan. It was a really excellent webinar, and we hopefully see you all at the next webinar in July. Take care, everyone.
Thank you.